Good afternoon, and I would like to welcome everyone in the network to this Monday session where we'll be discussing the HIV screening tools and its use. And today, our expert for the day is Dr. Albert Mwango, who is also the national chairperson for the TLD transition. But before we go into the nitty-gritties of today's deliberations, I would like to invite Madam Nomsa, who will give us a recap on the disclosure process, the discussion we had about 2 weeks ago. Madam Nomsa.
Good afternoon, everyone. I'm Nomsa Siamwanza, and we are a team from HW21. I'm joined by Lastina Lwatula. So I'm going to give a recap of our last session that was held on the 24th of June. And the topic, as it has been mentioned, was on HIV disclosure process. This had a bias on the children and adolescents. We had our two presenters. It was a co-presentation by Dr. Jinwala and Mrs. Joyce Mwanangombe. So what we learned in that session was that HIV-associated mortality was the 4th leading cause of adolescent deaths in the southern region of Africa. But we also learned that it is important to make decisions about when to start the disclosure process with children and adolescents. And this should be determined by the readiness of the caregiver and the developmental stage of the child. And then we also learned that children actually have the right to know about their HIV status, and that disclosure has many advantages. And these advantages are for both the caregiver as well as the child. We also learned that HIV disclosure is actually a process, and it is an ongoing process, and
we are unable
this
to
should
get
be done as a child disclosure. It must be determined. Hello?
We're able to get you. You can go ahead.
Okay, so maybe it was the network. Yeah, so I don't know where it ended, but I was saying HIV disclosure is actually a process, and it is an ongoing process which must be determined by the development of the child. And that there is no right age for disclosure, but that full disclosure must be done at the age of 12 years. It was also mentioned that disclosure is best done by the caregiver and the people that are trusted around that child or the adolescent. However, the healthcare workers do have a role to play in the disclosure process. So in a nutshell, that is a recap of the last session that we had. I hope you were able to get me. I think we dropped off briefly, but in summary, that is the recap.
Okay, thank you very much, Madam Nomsa. Yes, I think we seem to have a little bit of shaky connection, internet connection, but I think, we're able to get you. So I, again, would like to welcome everyone who has joined the network, and I think special mention goes to Ngombe and Charleston, I think, who are joining for the first time. And I can see that we have St. Francis, Livingston Central, Kazungula, and many others who have joined in the network. And I've also been taught Kanyama, although we don't seem to have the video, is joining for the first time. Please, if you're having any technical hiccups, kindly contact Mr. Chatonda so that you can be assisted, so that we would want to see the video of Kanyama. Oh, at least we have it now. Thank you very much. We are able to see you. So like I said, I think today we'll be talking about the HIV screening tools, and to help us discuss this will be Dr. Mwango, who is coming from CRIS. But before we go into today's didactic, we are going to invite Madam Catherine Mwango, who is coming from CRS EPIC 390. And she's going to share about the experience in the use of the HIV screening tool. Madam Catherine, please, you can go ahead.
Good afternoon, everyone. I'm Catherine Mwango, and I'm the HTS officer under the EPIC 390 project. So I'm part of the team that implements and mentors the activities in HIV testing. And today I'm going to just present the experience of Creso Ministries, which is one of the facilities that is supported under the EPIC 390. So I'll present on behalf of the site manager who's unable to present due to other commitments. So the first thing I'll mention is the objectives of the screening tool, which the screening of all the clients that are recommended for HIV testing. And then also the other objective is to improve the yield through the testing of all the modalities. So the background of the CRS EPIC 390 use of the screening tool. So we have 90% of our facilities that are using the screening tool. We have 75 facilities, and 90% of those are using the screening tool. But today's focus will be on the experience of Creso Ministries in the use of the screening tool. So the screening tool is used at the facility based, which is in OPD. So what happens at the facility is each client that walks in through OPD is screened before they are attended by the clinician. So the clients that are recommended for testing are tested and then later guided to the clinician with the test results, the HIV test results. And then, so for the screening tool, in OPD, the main screening tool is stuck on the wall to be used as a guide by the counselors that conduct the screening. So this is in OPD and in the VCT department. And the facility, the HIV screening tool is also being used in the community. So this is during the targeted community testing and during the conducting of index testing. And we've, from the time we started using the screening tool, we've noted two great successes, which is the reducing of the testing numbers and also the increase in the positivity yield. So some the comparison that we made at Creso Ministries is 2 months before the use of the screening tool, where we saw how many numbers they tested and the numbers of the positives identified. And just share the numbers of for the March and April testing numbers. In March, they had about 1,131 tested, and they identified about 217 positives. And then looking at June, the testing numbers dropped to 770, and the absolute positive numbers also went up to 268. And then there are some challenges that have been noted in the use of the screening tool, and these one of them is the screening of children, because we've noted that the children that are taken to the facility by maybe an older sibling or a guardian who doesn't know the testing history of the child, there's a challenge of screening the child because there's no consent to be given to have that child tested. So the solution to that is we're educating the guardians that take those children to the facility to educate them on the importance of having a child tested, and that information is passed on to the biological children who are supposed to take the children for testing. And then the other challenge that was being experienced was in the initial stages where we used to fill in a form for each client, and that brought in an issue of a lot of paperwork. And to sort out that challenge, a summary sheet was introduced. So this is a summary sheet where all the clients that are screened are listed on the summary sheet and all the details are collected. So this summary sheet also helps in in recording and also has reduced on the paperwork. And then the other challenge is some of the community health workers in these facilities have not fully grasped the concept of the use of the screening tool. And to sort out this challenge, we are making sure that all the community health workers are fully mentored, and this mentorship is continually going on to make sure that all the community health workers are using this tool effectively. So this is just a short experience of one of the facilities, and this is happening in all the CRA-supported facilities. Thank you.
Thank you very much, Madam Catherine, for sharing with us your experiences in the use of the screening tool. And I think at this juncture, I'll now invite Dr. Mwango, who is going to take us through today's didactic on HIV risk screening tools. Dr. Mwango. Dr. Mwango, are you? Hello?
Hello, can you hear me?
Yes, we can.
Yes. All right, I'll get started. We can advance my slides. Right, as I was saying, I'm Deputy Chief of Party Technical, and I have no interest of disclosures to declare. Next slide. The objective of this presentation is to explain the rationale for introducing the HIV risk screening tools in Zambia. The second objective will look at the process of introducing the screening tools in Zambia. Before we go into the nitty-gritties, we'll have 3 polling questions. The first one is coming up, and it reads as follows. The Zambia HIV risk screening is most useful in identifying patients that are HIV positive. Is this true or false? A is true, B is false.
Yes, so thank you very much. We can now begin our voting. The first poll question is, the Zambian HIV risk screening tool is most useful in identifying patients that are HIV positive. Is this true or false?
Dr. Mwango, the answers are both false there, so maybe if that can be corrected.
Right, the first one is A is possibly true, and B
Dr. Mwango, sorry, Dr. Mwango. What we do is that it's a poll question, so people should have to vote either false or true, and then afterwards we'll discuss, and then we'll give them the chance to understand why the questions have been framed like that.
Yeah, it's appearing as false, so I was correcting the options. Option A is supposed to be true. Option B is supposed to be false.
From where I stand, it's true and false. Is it on the poll question? Oh, sorry, sir.
True and false.
Okay, I think the one on the slide, if people have seen the slide, please, that's how they are supposed to be. All right, yeah, I think on the poll, yes, it's false, but A should be true. So only 30% have voted, please.
The question has disappeared.
Sorry, I think there was a break in the network. So if we can re-vote, because we have relaunched the poll. Okay. Okay, thank you very much. We'll move to the second poll question.
Yes, please. Right. The second poll question reads, the Zambian HIV risk screening tool can reduce over-testing by A, 20 to 25%, B, 30 to 40%, C, 80 to 90%.
Okay, thank you very much. So we'll go to our second poll question. The question is, the Zambian HIV risk screening tool can reduce over-testing by, so A, 20 to 25, B, 30 to 40, and C, 80 to 90%. Only about 50% of us have voted. Okay, thank you very much. We can go to the third poll question.
Thank you. Zambia advocates for universal testing. So use of a screening tool is not yet Ministry of Health policy. True or false? A, true. B, false.
So there we go again. We can vote for the poll. So Zambian advocates for universal testing. So the use of screening tool is not yet MOH policy. Is this true or false? A few more votes are being awaited. Okay, thank you very much. So we will come back again to discuss the poll question, but for now we can go ahead with the presentation. Dr. Mwango.
Thank you so much, Dr. Mpeta. Right. As we all are aware, Zambia has got a population of approximately 17 million people, and it's estimated that 1.2 million of these people are HIV infected. 1.1 million are adults, 72,000 are children. This is the UNAIDS 2018 report. And from the Ministry of Health, we have reliable information that we have crossed the 1 million mark of people on ART. So 950,000 adults are on ART, and about 50,000 children are on ART. So quick calculation would imply that we have 172,000 Zambians out there who are living with HIV and are yet to be identified and started on ART. Next slide. Now, a reality check in terms of identifying these individuals. There's a concept known as the number needed to test in order to identify those that are HIV positive, using the universal testing approach, which has been policy for Zambia for some time. For adults, to identify one positive, we have to test a total of 22 individuals. So this is the NNT, or number needed to test to identify one positive. To find one positive, you test 22 people. It's a sort of yield in a way, which we'll look at later on. I think we are all very familiar with yields, which is just a basic percentage of those who are positive out of those that have been tested. So this is another way of looking at the same thing. For children, to identify one positive child, we currently, using the universal testing, have to test 151 children just to find one positive. So you can imagine, if you look at yields in this way, how many people we have to test just to find those 172,000 people. Next slide. Right, so what are the implications of these high NNTs, 22 and 151? Basically, it implies that we end up with having low yields, and NNT is really just an inverse of the yields that we are very familiar with. There's also the implication that there's over-testing. Too many tests have to be done just to find those individuals who are HIV positive. There's also a cost to testing, and this cost includes time for the counselors, the reagents, and a few other things which have to be done just to get an HIV test. And this has been found by a study by Mwango and others, that it costs about 55 kwacha per person. So imagine how much we are spending every day when trying to find that one positive. It is also time wasting because every test requires about 15 to 30 minutes. The test itself, 15 minutes. Interacting with the client, a few more minutes. So approximately close to 30 minutes per test. And to test 155 people means a lot of counselors are needed, lay counselors or volunteers, which is also quite a big toll on resources. And there's a high chance of missing patients, especially in situations of high volume patients who need to be screened or tested. Like in a busy OPD, not everybody gets a chance to be tested for HIV using the universal testing approach. Next slide. So how does an HIV risk screening tool work? Well, basically, think of it like as if it were a lab test, except it's a cheaper way of doing things. It takes less time, it's easily administered. And if we had, for instance, 10 patients or children in which one was positive and we knew that these were positive and we applied the two, when the two is applied, it has a way of discriminating who should be tested for HIV because they've got a high chance of being HIV positive. So the screening tool, when it is applied, will recommend certain individuals to be tested based on their characteristics from asking them the questions. So in this illustration, on the top, we have 5 babies or 5 children who actually are not recommended for testing, and they're actually not HIV positive. As you can see, the cartoon there is in black. So the tool is helping us screen out those without disease. And remember, we were talking about how many people it takes to just find one positive. Ordinarily, we would have to test all these 5. But because the screening tool also makes a recommendation of who to test with determine, it will only give us 5 other children, including the one that is HIV positive. So this characteristic is very important for us because there's a quality of any test which is known as the negative predictive value. And the negative predictive value is just a probability of someone who a test says they don't have a disease actually doesn't have a disease. So our screening tools will show very soon in the validation we did, show that they have a negative predictive value of more than 98%. So in other words, if our test tells us, if our screening tool tells us don't test this child, there's a 98% chance that this child does not have HIV. Next slide. One thing we need to also emphasize is that there are 2 tools to be precise. There's the adult tool, which has got questions tailored for adults. And then there's also a pediatric tool, which is tailored for children. With the adult tool, there is need to verify if they've previously tested and need retesting. Maybe they've had high-risk encounters, which would require them to be retested. This is not so in the children. The screening tool for adults has got 5 items or 5 questions. And this is based on a tool called the Banderson tool. This is a tool which is commonly being used in many countries, Uganda, Zimbabwe. Its origins are in Zimbabwe, and it has done very well in those countries. So we adapted our tool based on those, on that tool, the Banderson tool. There's some links down there. People can follow them up if they want to read a bit more about them. There's also guidance in the adult tool on who should get HIV testing or TB. testing, and who should be followed up for STI testing. Testing recommendations based on the questions. If the questions are yes to any of those questions, that person is recommended for HIV being determined. Now, there are times when clinicians feel the two may have made a mistake. They feel they need to explore the situation where this child or this client needs to be tested. They can overrule the screening tool. That is the vision that has been put in the screening tool. So they can go ahead and still test that individual, even if the tool recommends that they should not be tested. And the outcomes of this process are recorded in what Catherine mentioned earlier on, which is the summary or tally sheets which have been introduced in the facility to make documentation easier. On the flip side of the adult tool, there's a retesting guidance which tells you who should be retested or not based on their risk characteristics. So that's on the flip side of the tool. Next slide. This is an example illustration of the retesting guidance, which has been extracted. These guidances have been extracted from the Zambia Consolidated Guidelines 2018, from the HTS Guidelines 2016, and from the WHO document, which was done some time back in 2010, called the WHO Retesting Recommendations. Next slide. The children's tool, like I said, is a bit different from the adult in that retesting eligibility is not recommended after someone has tested for the first time until they are adult or they become sexually active. In situations where a child may be thought to have been abused or sexually abused, this retesting can be recommended. Otherwise, we only do one test for children, because how else can they be exposed to HIV? The screening tool contains 6 items or questions. Again, it also recommends for TB and STI testing, and gives recommendation of who should be tested and who should not be. And even in this tool, the clinician may overrule the screening tool recommendation and go ahead and have the child tested. And documentation is also with the use of the summary or tally sheet. Next slide. Next slide, please. Right, this is a look at the summary sheet in terms of how it looks like, and this is the one for children. It basically records row by row every client. Before, as Catherine had mentioned, we used to fill out a whole sheet of information for one patient. Now imagine in an OPD where you have in a month maybe 2,000 people passing through. That would mean you'd acquire probably 4 reams of paper just to record all their encounters. So we designed this summary sheet to record this information with ease so that it can be referred to for reporting purposes. It's a simple tool that can be applied at any facility. It records the serial number, patient initials, the sex, age. SDP is basically entry point. That is the service delivery point. So if it's being applied in the OPD, they'll just record OPD under SDP. And then it answers, it records all the answers that are obtained when the tool is administered, right up to the point when the individual is tested and their results. At the bottom are just some summary of how many have been screened, how many got the HIV test, and how many were positive. Next slide. This is an illustration of how this information which is collected can be reported. For instance, in OPD, we see how many attended OPD. If there was 120, that would be listed in the first bar of this chart. How many were screened? How many were recommended for an HIV test? How many were not recommended for an HIV test? And how many were tested from those that were recommended for an HIV test? And ultimately, how many were positive? Next slide. Right. I mentioned earlier on that the tool that we are using in Zambia is based on the Banderson tool. We had to create one which is meant for Zambia and had to validate it, meaning see how it works in our environment. And at CRS, we introduced it in 16 facilities that were able to collect information at the time by 1st April. And each were required to collect information for 100 adults and 50 children. Next slide. These were the results. As you can see, we reached almost 1,300 individuals. And for the adult, we had 876 adults come through who were given the two. 476 were recommended for testing, and the two did not recommend, about 396. Ordinarily, in universal testing, all 872 should have been tested for HIV. But these two did not recommend 396, so only 476 were tested. And amongst those, only 31 were found to be positive, and 446 were HIV negative. For children, 303 children came through, and 180 were recommended for testing, 123 were not recommended for testing. When the recommended ones were tested, 2 were found to be positive. And you can see that that period of validation, we went on to test even the ones that the 2 had not recommended. And we found that the ones that were not recommended, 0 were found to be HIV positive, and 123 were negative for children. Let's look at what that implies when we do the numbers. For adults, it means under universal testing, we would have done 872. But with the screening tool, we only did 476. The number needed to find one positive under universal testing is 21.8, which is the 22 we were talking about earlier. But with the screening tool, it took only 15.4 people to be tested to find one positive, which is a reduction by 30% from the universal testing. The yield under universal testing was 4.6%, but with the screening tool, it rose to 7.0%. When we applied the retesting guidances, under universal testing, everybody is tested. But when we use the screening tool and the retesting guidance, 196 should not have been tested. And in the validation, we did test them, and we found that they were all negative. So the validation also looked at the retesting guidance. For positives, we found 40 under universal testing, but under the screening tool, we only found 31. So this implies that our 2 missed about 9, which is 23%. So that is some of the negative side of screening too. Sometimes you can miss some positives, but you have to weigh the advantages of the 2, and the disadvantages is one of these, missing some positives. You can see for children, we had 303 tests done under the universal testing, screening 280. The number needed to find one positive under universal testing is 151, which we talked about earlier. But under the screening tool, it's 90, a reduction of 40%. So from adult and pediatric screening tool, there's a reduction of 30 to 40%. I'm sure that sounds familiar now. For the yields rose from 0.7% under universal testing to 1.1%. Retesting, of course, we don't apply this to children. In terms of positives found, 2 were found using universal testing and 2 were found using the screening tool. So all the 2 were found by both tools. I mean, both approaches, universal testing and screening testing. The MVP negative predictive value for the pediatric tool is 100%, meaning there's 100% chance or probability that the children who are screened out by these two are not going to be HIV positive, are actually going to be negative, which is a good thing. So that's what we are interested in. How many we can rule out from being positive. Not how many can be ruled in to be positive, but ruled out. So we're interested in the negative with the screening too, so that we don't waste resources on those that the two tells us are negative. Next slide. So applying the screening tool in practice, where to use? We recommend that it's used in low yield modalities, like in the OPD, in VMMC, where we see 0.2% yields. In wellness clinics, children who are coming in for immunizations and they're not sick, we don't recommend, we recommend use of this too. We don't need to exclude this. Community testing, where following up contacts of index testing. And by this, what I mean is when we go out into the community trying to get a contact, we sometimes do some unnecessarily testing of people around that person so that we don't arouse suspicion. These are the ones we can apply the screening tool on. And then also PP-Prev testing activities. We go to, we have a testing day and we go out and test almost everybody at random. That's where we need to screen down. Otherwise, we can end up testing too many negatives. So where not to use the screening tool? These are areas where the chances of these individuals getting these forms of services, there's also a high probability of them having HIV. Like TB patients, there's a 60% chance that they can have HIV. So we don't use the tool there. In patients in the wards, we don't use the tool there. In malnutrition units, HIV is known very well that it can cause malnutrition in children. In the STI clinics, after all, HIV is an STI. VCT, when somebody demands an HIV test, we're not supposed to use the screening tool, so we shouldn't turn them away. If they are coming to us and they're asking for a test, let's give them the test. And in men over 25, because there's so few men who have been found, we will recommend that you use an HIV self-test. But if it is overwhelming, say in OPD and you've got a lot of people, you have very few time, very few CBVs, you can use the screening tool, but we don't recommend necessarily to use this tool in men over 25. I'm sure we can think of other places where we can use or not use the screening tool. We come finally to the question about screening tool and MOH policy. I think in April this year, we got a communique from Ministry of Health, and there it says, there's item number 2 in this fast track memo for epidemic control, which says, avoid repeating HIV testing in individuals recently tested for HIV negative, and they have no recent HIV exposure, high-risk exposure. Use of a screening tool will help to determine risk and guide how often individuals should be tested. So that is our guidance for using the screening tool in our facilities, and that is MOH policy. I'm sure this sounds familiar now. Next slide. Just some references which you can go to when you have time to get more details on this topic. It's a very interesting topic, and I think it will assist our country and facilities to actually provide services where they are most needed. I'm also available on email for any consultation or feedback.
Okay, thank you very much, Dr. Mwango, for that presentation. And I think now we are going to go through the pause so that we can discuss. So what's going to happen is that we will relaunch to see if learning has taken place. So please feel free to participate in the pause. So we'll go to the first one, of which I have launched again. So the first one is the Zambian HIV risk screening tool is most useful in identifying patients that are HIV positive. True or false? So note that A is true, B is false. Okay, we can see that a number of you haven't voted, about half of us. Please, I can see people are still hesitating. Kindly give it a try and then we'll discuss. Okay, thank you very much. Dr. Mwango,
Yes,
if you could share with us what the correct answer is. About 75% have said this is true, and about 25% have said it's false.
Right. Yeah, I think that point needs to really be re-emphasized. The Zambia HIV screening tool is mostly about eliminating those that are HIV negative from being tested using determinant. Our tool has got a high negative predictive value, meaning that the probability of any individual which the tool says should not be tested is that that person doesn't have HIV. So it has 100% for children. So if the tool says don't test this child, then it means there's a 100% possibility that that child is HIV negative. And for adults, it's 98%. So we are interested in eliminating the negatives. If you remember the cartoon I shared with you, which was showing number needed to test, if you can eliminate most of those negative people without eliminating the positives, then you will have less resources being used to find those positives. So the answer is that this is false. The tool is most useful in identifying HIV negative, not HIV positive. That's why we still have those determine and bioline to tell us who's positive. So the job for that is the bioline and the determine. But the tool is to tell us who is not HIV positive, who is negative, so that we don't waste those resources on them.
Okay. So thank you very much. So in a nutshell, to just our colleagues, this 75 who said it's true, the screening tool is meant to identify which person is likely going to be negative. So where it says positive, there should have been negative, which makes the answer false. So we shall go to the second poll question, of which I'll relaunch again. So the second one is the Zambian HIV risk screening tool can reduce testing by A, 20 to 25, B, 30 to 40%, C, 80 to 90%. So we can give it a try, and then we'll ask Dr. Mwango to assist us in understanding what these numbers mean. So quite a good number have voted. Please let's ensure that we participate. Okay, so thank you very much. So I'll share the results. Dr. Mwango, about 5% have gone for A, which is 20 to 25, and about 69% have gone for B, which is 30 to 40, and 27% have gone for C, which is 80 to 90%. Your comments?
Right. I think the 69% have got the concept and also followed the discussion. The number needed to test, like for instance, for children, 151 children to find one positive. When we apply the screening tool, this reduced by 40% to 90 needed to find one positive. So that's for children. And in the same application, we got 30% reduction for adults. So the correct answer is 30 to 40% reduction in over-testing. So we are over-testing by these numbers because we are not applying the tool. So the correct answer is B, which is 30 to 40%.
Okay, thank you very much. So at least the majority here 70%, I think, have gotten the concept. We hope that it's clear now for the other 32%. We go to the last poll question, and then we'll invite questions. So the last poll question goes like, Zambia advocates for universal testing, so use of the screening tool is not yet MOH policy. True or false? Okay, so only a few, I think, about 70% have voted. So the results as follows: 8% have gone for true, and 92% have gone for false. Dr. Mwango, comment.
Yes, I think we need to revisit the memo for the 8% that have said this is true. Because that memo which I shared basically says we can use the screening tool as we are providing our HTS or HIV testing services. So the 92% are correct in saying that this statement is false. We have a policy by virtue of that memo which was issued in April 2019.
Okay, so thank you very much. And I think we have gotten what the concept is about this. And I think what's the final word is that the memo is here, that means it's policy. We don't have to wait until it's printed in the guideline.
On next week.
Okay, sorry, there's madam there whose mic is not muted. So I now open it up for questions. And I think the first question is coming from, we don't know. This person is just called Techno. So they haven't put their name here. They are asking, should the screening to be used at cervical cancer screening departments or units? Dr. Mwango.
Right, that's a very good question. When we were validating the tool, we looked at areas where our current yields are less than 5%. So my question would be to Techno to say, what are your current yields in the cervical cancer screening department? Meaning, for every 100 patients that you test for HIV, cancer patients that you test for HIV, or cancer patients who, not patients rather, people who need screening for cancer, how many of them are actually HIV positive? If it's more than 5 out of 100, which is 5%, you would not want to use the screening tool. But if it's less and you want to improve the number of people that you are eliminating from unnecessary HIV testing, you want to do that. So it's best to go back and look at your situation. Remember, this tool is very sensitive to the prevalence. So it can even differ from one part of the country to the other. You may not get the same results across board. Dr. Peter, we can't hear you. You're on mute.
Sorry. Yeah, so I was saying, Kanyama, I've got a question. I don't know, have they been muted? Muted?
Yeah.
All right, so Kanyama is participating for the first time. So it's quite encouraging to see that they're actually asking a question. Kanyama, please go ahead.
Thank you, Dr. Mpeta and Dr. Mwango. It's Dr. Katamba here. I have a question. I understand, Dr. Mwango, that the screening tool will help us to identify clients who are likely to be HIV negative and avoid over-testing. But you also mentioned that this screening tool missed 9 clients. So in terms of sensitivity, we don't know what that 9 clients represent. My question now is, what are we going to do, or what measures are we going to put in place to avoid missing clients who may be HIV positive? Thank you.
Okay, thank you very much. And I think, Dr. Mwango, the same question has been asked by Theodora Savory, I think about missing 9 positives. And if this is not too much, especially that we are looking at eliminating HIV. So please, if you could combine.
Right. It's a very good question. And this is where an HIV testing or HIV risk tool comes into some, because there can be some false negatives. You can declare false negatives. But this is a reality in almost all situations. This is why we encourage clinicians to see patients after the screening. And if there's a reason that can determine or change the testing decision based on the tool, please change that decision and test that individual. But nonetheless, if you have no reason to suspect that the tool is wrong and the patient has answered correctly and truthfully, please go ahead and not test, and only test the ones that are recommended. Now, the question as to whether this is too high or too low, it's a balance. Right now, we are having a situation where we don't have enough test kits in the country. So the little resources that we have, if they can be used wisely, they can help identify a large majority of individuals without the unnecessary resource depletion. So it's a give and take situation, and there are some population which we're recommending that we use the HIV self-testing kits that are in the country. That can also help, and also it is also very important that you have a balanced mix. If you are missing too many positives, obviously it may have been applied in situations where patients may have probably signs and symptoms of TB, and somebody didn't even bother to look at that situation. So what we recommend is apply all the screening, because even the TB screening questions is actually a screening tool, and we use it diligently. So let's use everything at our disposal, all tests available, all screening tools available to find each and every one of those individuals that are out there.
Okay, thank you very much. I think we've got a hand from Nangongwe. So Nangongwe, if they could come through with their question. And just, I think before Nangongwe comes, there's a question. How about use of the screening tool in GBV and victim support corners? Dr. Mwango, any thoughts on that?
Right. Usually that's high risk. And using a screening tool in a high risk situation like gender-based violence, especially if we're talking about sexual abuse, it would not be prudent. I would not recommend using it in that situation. Best to go ahead and just do the bioline and determine, and then if that is indicative to bioline. So don't use the screening tool in high-risk situations like sexual abuse.
Okay, thank you very much. So Nangongwe, if you can go ahead, and then after Nangongwe, we are going to have Sons of Thunder. Can we unmute Nangongwe? It's kind of a tongue twister. Okay, I think we are failing to unmute Nangongwe. So Sons of Thunder, please go ahead with your question.
Hello, good afternoon.
Good afternoon.
My question is on the VCT. When we're looking at the list that we are not supposed to use the screening tool, VCT is one of the places where we're not going to use the screening tool. Now, according to my experience, maybe it depends where you are. What I've observed is people who know their status, they are not difficult to come for testing. You find most of the people who come for testing, voluntarily, they already know their status. Maybe they tested somewhere recently, so they'll just come to the clinic voluntarily to say, may I be tested? So on VCT, to me, I feel people who already know their status, especially the negatives, they are not difficult to come for testing. But those who do not come for testing are the problems patient. Thank you.
Okay, are you agreeing with Dr. Mwango that we should not use it in VCT, or what's your question or clarification?
I thought you were saying in VCT we shouldn't be using it. Yeah.
Yes.
So to me, I feel we need to be using it because most of them, according to my experience in the rural areas, I'm working in the rural areas of Kazungula, and most of the people who come when we test it, voluntarily they come out negative. So I feel we need to be using the screening tool in the VCT clients.
All right, so I think the concern, Dr. Mwango, is that since the screening tool is meant to identify the negatives, and their experience is that actually those who come for VCT are HIV negative. So why shouldn't they use it? I think that's the concern.
Yes.
Right. Well, it's a very interesting question, but you have indicated that the premise is that they are not telling us the truth, and that's why they are testing. So if you know they are already HIV positive, how did you know that they are positive? Because if you know that they are positive and there's some evidence that they are positive, then the screening tool, this allows us to actually test them. If you follow the screening tool very carefully, there's where it says, have you ever been informed by a provider that you are HIV positive? Or there's some evidence maybe in the file that says that patient is positive, then we shouldn't test. It goes in another direction which says do not test, link to care. That's how the tool works. But if you have a patient where that information only came out from probing, then you've done the right thing as a counselor by probing to find out if they already know their status. And again, the conclusion is do not test them, because the screening to direct you in the direction where you need to link them to treatment. Now, if they say, Kufwana no, and I will not divulge, I don't know my status, but I want to be tested, and the truth is that they were already tested somewhere else, you will not know. So you would have to provide the appropriate service. This is why if a patient volunteers in this day and age where we are, and I'm saying we are in the last mile of identifying people who are HIV positive, we need to be very careful. We need to be skeptical. We need to probe. Let's not harass our patients in telling, tell us, have you been tested before? No, let's be gentle. Let's talk to them as to why they need to just own up and get onto treatment, because that's the most important thing. If they are looking for another result because they've been maybe on treatment for some time, or they've experienced a miraculous healing of some kind, that's a different psychosocial problem that we need to handle and explain and educate our clientele. So remember, be a counselor and provide the appropriate services, provide the right guidance. Testing in VCT should not be hindered. If someone has probably had a high-risk encounter, they want to test, and they will come and say, please test me. So if we turn them away, we are missing an opportunity. Those are the ones that will be missing the 9 patients that we have missed previously. Dr. Mpeta, we can't hear you.
So, sorry, I'm saying I've noticed 2 hands from H. Sakala and Tabiso, but before they come in, there's a question from Leonard, and he's asking that during the validation or after the validation, was the screening tool modified so that we reduce the chances of missing the 9 clients who tested positive?
Right, a very good question. It's a question we are still looking into. We have not modified the tool, It is still based on the ones that were validated. We've changed the language a bit here and there to meet the requirements that the Ministry of Health had demanded. And also we added 1 or 2 extra questions, which might be able to reduce the chances of missing. But that has not been validated. So during the validation, we didn't do any modification. The results you saw are based on the original tool that was administered in the facility, the 2016 facilities that CRS supports. There was no modification.
Okay, thank you very much. There's another question from a person who is only identified as techno. Please kindly identify yourself so that we can fully incorporate you instead of just looking at the phone's name. We want to associate the person. So Sakala, I think, can go ahead. H. Sakala.
Thank you so much, Dr. Mpeta. I wanted to just find out that we have some clients over time of us using this screening tool definitely get used to understanding what this screening tool is about, and they may be responding to us, telling us the answers because they know that what we are expecting from them, and that may be compromising on the effectiveness of using the tool. This is picked from the observation of psychosocial counseling. We've noticed that over time, we've come across clients that would actually give you the whole psychosocial thing before you even provide any service. And all they will tell you is just, I already know the question you asked me, whether I'd sex with someone that a condom, whether I risk and whatever, just test me. So how do you do with such situations so that we can still appreciate the tool? Thank you.
So just out of curiosity, for how long have you been using the screening tool?
No, I'm not using the screening tool now. I'm just speaking from the past experience psychosocial, where we've observed that over time, some clients, all the questions in psychosocial even before you say anything. And remember that these clients, it's not the first encounter they may be having with most of us. They could have been exposed somewhere else where these questions, similar questions could have been asked, and over time they get to understand that it becomes a routine.
So, Dr. Mwango, any thoughts about people wishing to beat the screening tool?
Yes, that can happen, and that has been observed with many screening tools, including our TB. I mean, you ask somebody, are you coughing? They say no, but then they cough, and it's a terrible cough. So it has been seen that there are, individuals who do that. So what we do is we ask clinicians to be vigilant. Let's not put our guard down because the screening tool is being administered by counselors or providers. As clinicians, we still need to continue being vigilant and provide provider-initiated testing and counseling. It is not, the screening tool does not negate the need for PITC. So that needs to continue. And this is why clinicians see the patient after the screening tool has been applied so that they can make their determination. So please, all clinicians, nurses, doctors, medical licentiates, clinical officers, let's be continuously vigilant to talking to our patients and probing. Sometimes they can try and beat the system, but then when they see the white collar, the white coat, and the doctor talking to them with some authority, then they tell the truth. So let's not lose that as clinicians, and let's continue being interested in our patients and probing.
Okay, thank you very much. Tabiso Moyo, could you kindly unmute yourself and go ahead with your contribution? We have failed to unmute you from our end.
Okay. So,
kindly ensure that the other devices you have are muted. Are you there?
Yes, I am. Just give me a second. Okay, am I clear now?
Yes, you are. Thank you.
Yes, so my contribution is the usage of the screening tool is not supposed to negate the counseling skills and the provider skills. So the screening tool is just there to enhance our service delivery. So if we've got a client, we should also be able to use our clinical judgment as clinicians. We should also be able to use our skills as a counselor, whichever client that comes in, that comes through. It's not just a matter of, administering the tool as a routine, but also we need to have that interaction with our clients and should be able to judge our client, the client that we're dealing with. That way, that is the only way we're going to use the tool effectively, and that's the way the tool is going to help us drop our yield. and not just using it as a routine just because it's a screening tool, so we use a screening tool. No, but as counselors, as service providers, we should be able to, just have that judgment. That's why there's even that provision at the end of the screening to say that a clinician may, despite the client giving those answers according to the screening tool, but the clinician may say, okay, you know what, from my judgment, we need to still continue to provide this HIV test to this particular client. Thanks.
Okay, thank you very much. And I think just emphasizing the need that we need to pay attention to details. Now, Ngongwe, if you could kindly unmute yourself as well, then you go ahead and make your contribution.
Thank you very much, Dr. Mpeta. The team wants to find out with regard to the testing targets. Now that we're using a screening tool, do we really need testing targets in the facilities, and should we maintain testing targets? Because sometimes we feel maybe the set targets are the ones that are making us to maybe overtest because we're trying to test so as to meet the targets. So with the use of the screening tool, do we really need the testing targets? Thank you very much.
Dr. Mpeta, I couldn't hear what you just said.
I'm saying, any thoughts about the Nangongwe's concerns about the testing targets and the use of the tool?
We need to have testing targets, except we should not be focusing on how many tests we've done, but the quality of testing. How many positives have we identified from the number of tests that we have? The example Catherine shared with us showed that this facility still maintained its number of absolute positives identified. They did less tests, but found the same number of, in fact, found more. They found over 420 positives, and they only did less than half of what they did the previous time when they were not using the screening tool. So Creso Lusaka was able to demonstrate that they could maintain the absolute numbers of positives identified from doing less tests. So the target should be more positives for less HIV testing. That's what the targets need to start reflecting now. So we shouldn't just look at how many tests did we do, even if we found zero positives.
Okay, thank you very much. And I think Chilenge has got also an interesting, thought to share. And if you could just come through Chilenge first level. And I think, yes, there's some mathematics here that you have done, but I think it would be best if you could share to the network.
For Chilenge Hospital,
sorry, we kindly get near the microphone.
Okay. For Chilenge Hospital, about 3 weeks ago, we're trying to make sense of why we're getting very few positives. As an instruction from CIDES, we were requested to try and also validate that tool in our setting. We got 84 clients at OPD consecutively coming in, and we subjected the screening tool to all of them, but then tested them irrespective of whether they were eligible or not. Of those that we screened, 48% were not eligible, 48 were not eligible, yet 12 turned out positive. Still, of those not eligible, the others were negative. Of those who are eligible, only 2 turned out to be positive, and we had some forms that were not appropriately filled in. So our concern was that of the people not eligible, 25% were positive, which is quite big. So we acknowledge that we have a very small sample size, and of course we need to have bigger numbers to make more sense out of this. But I think it goes back to what Dr. Mwango said, that maybe this needs to be customized as per the prevalence of the setting.
Okay, thank you very much. So some interesting, I think we'll be interested to see actually all the validation report from Chilenge, including the negative and positive predictive values for the sample size that you did. It will be useful so that we can see how in different settings the tool is being applied and what the yields and the predictive values are. So thank you very much. And I think I don't have any questions. I can allow one burning issue, if there is one, before we allow Dr. Mwango, just to give us his brief conclusion about today's discussion. I don't seem to see the hand. Chatonda, can you see anyone trying to? I think there isn't anyone. Dr. Mwango, any last thought about that presentation?
Right. Just, I think, a quick comment on the last Chilenge contribution. This is where we're saying when applying the tool, do not apply it in a situation where you've got a high positivity rate currently going. It will dilute your results. Instead of getting the effect that you want, you get the opposite. Like I mentioned, the screening tool is like a lab test. If the chances of finding a positive are very high, don't screen. That's the first rule about screening tools. If the chances of finding a positive are very high, don't screen. So every time the prevalence changes, the tool becomes less reliable. In fact, this tool, which is highly specific, has got a high negative predictive value, is only useful when your prevalence is low. You tweak that and you put it in a place where there's a high positivity rate, the tool becomes very difficult to use. You get a lot of false negatives from the tool. And those are actual individuals who have got. So this is why Dr. Mpela is saying, let's look at your full data set and look at also the characteristics of those patients that you are actually administering the tool to, and the prevalence in your OPD. If your OPD has got a very high prevalence, please don't use the screening tool. But you need to verify that it's true you don't have a high prevalence in your OPD before you make the decision not to use the tool. So my final remarks are that, one, we are in the last mile of case identification. We are looking for needles in haystacks. So we need to use every opportunity and tool that comes along that helps us make our work a lot easier, helps us conserve our resources. The second point is that we need to reduce the number of negatives that we are finding. Finding a negative person is not very helpful for us to come to epidemic control. Yes, it's good if we're finding more negatives on an individual level, but for the sake of the epidemic, we need to find the positives. I know there's that ironic celebration when we find positives. We are not enjoying the misery of others. It's just that we know by finding them, we can give them the service that they need. They can go on ART, they become virally suppressed, and that will help us curb the epidemic that we have had for quite some time now. It's now going to 30 years or so. And lastly, remember the screening tool, if used in the right place and appropriately, it will help us become more efficient. We will do 30 to 40% less testing. We will spend less resources on testing. And finally, remember that the screening tools are Ministry of Health policy. Those are my closing remarks. And thank you so much to the ECHO team for allowing me this privilege to share some insights on this very important topic. Thank you so much, and God bless.
Thank you very much, Dr. Mwango, and Madam Catherine Pili, who was also with us sharing their experience in the use of the screening tool at CRESO. And I would like to thank everyone in the network for having made time to join us. Initially, we thought there were very few people who have joined, but I think as we went along the presentation, we've seen a number of people and facilities who have joined, which is quite encouraging. So for now, I think I will ask Madam Nomsa to give any announcements that we have for next week's session.
Thank you so much, Dr. Mpeta, and everyone in the network. Thank you so much for joining in. Would like to still encourage the network to join in. First, join in on time so that we can check we can check on you. We ask that you join in at about 14:15 thereafter, as opposed to joining in at 14:30 or afterwards. But also I want to call upon the mentors that are in the network. We are seeing a dropout of some of the facilities. They are not joining in. So could you please just check on the facilities and encourage them to join in for these echo sessions, because continuity is what will make a difference in their.
Okay, are you still with us, Madam Nomsa?
Practice, but if we do have people that are not, come again. Hello? Hello? Are you getting me?
Yeah. Yes, we are.
So, so I was just encouraging the mentors and other individuals from other facilities that please encourage. We've seen a dropout of some of the facilities. We know we've had about 87 connections, but quite a number of them are individuals. We want the facilities, the teams that are on ground and they're practicing, because this is very important for those that are actually on hands-on in terms of information, influencing their skills. So please encourage others to join in our next session. Our next session, we hope that if the topic doesn't change, will be on cervical screening and HIV. So please look out for that topic and let's join in. And remember to submit your registers for those that participated today. Thank you so much.
Okay, thank you very much, Madam Nomsa. And I think I'll just leave this with the network. I have seen that there's still a little bit of confusion about the real reason why we're using